So why are we learning vascular anatomy? Because the pattern of brain involvement often indicates the cause of the patient's symptoms and the cause of the infarct. And the other reason I think it's important to understand the specifics of vascular anatomy is because when you see involvement of multiple vascular territories when they're adjacent to each other, you have to start thinking about a non-vascular cause. For example, if you see involvement of the medial and lateral temporal lobe, it's very unlikely that you're dealing with a stroke. This is more likely to be a tumor or infection or something of that sort. So I want to try to get into some of the details of vascular anatomy. So I'm going to start with this case. This is a normal vascular study. And so just to review, and for some of you, this is really elementary, but I want to, as I say, I'm going to start with basics and bring everyone along together. So again, on this slide, you can see the two A2 segments of the anterior cerebral artery. You're seeing branches of the middle cerebral artery here in the Sylvian fissures. As we move down, again, you see the A2 segment and the A1 segment. So this is the first part of the anterior cerebral artery. And these are joined then by the anterior communicating artery. And here we're starting to see part of the M1 segment of the middle cerebral artery. And here's the other middle cerebral artery. So M1 segment, MCA bilaterally. Now we're at the distal carotid artery on the right and the left. You're starting to see the ophthalmic artery. Now, in terms of the anatomy of the carotid, some of you may have learned that the ophthalmic artery is a good marker for the distinction between the cavernous carotid and the intradural carotid. And of course, that distinction becomes very important when you see an aneurysm in the region of the dural ring or the ophthalmic artery, in the sense that aneurysms that lie within the cavernous sinus are not at risk of, for the patient of a subarachnoid hemorrhage. Those aneurysms that cross over the dural ring into the intradural space are then a potential source of subarachnoid hemorrhage. So that distinction between the cavernous carotid and the intradural carotid is important. The marker I think you should learn to use is not the ophthalmic artery, but this structure here, which is called the optic strut. The optic strut anatomically correlates very well with the dural ring. So aneurysms that lie above the optic strut are intradural. Those that lie below the optic strut are likely to be cavernous. Now, some aneurysms occur just at the dural ring. We're not going to get into that in this course. If you want to learn more about reading CTA and some of the detailed anatomy, I'm going to refer you to one of my free online resources. It's a textbook. It's like a really more like a picture book. It's available on the iTunes store. It's an iBook. It's called Learn to Read CTA. It's pretty easy to remember. It has my name. But in that, I go through some of this detailed anatomy of the dural ring. So we'll keep going down. So now we're in the cavernous carotid artery, and we're starting to see the posterior cerebral branches. This is the patient's posterior cerebral on one side, here on the right side, and that will leave us down to this point. This is the tip of the basilar artery. Now, this point here at the top of the basilar, when it divides into the proximal P1 segment, these are the posterior cerebrals coming off of the basilar. You see this little dark space in between? So we'll see this in some of the following images in reconstruction, but this is what tells you that this patient does not have a basilar tip aneurysm. So look for that little gap. But again, of course, you're going to look more carefully at the anatomy in other constructions. This is the superior cerebellar artery. And then as we come down where this is the basilar, we can't see them, but there are perforating branches that come off the basilar. And then this is the petrous portion of the carotid here, petrous portion of the carotid here. In this case, this is another patient with what is effectively normal vasculature, There's a vascular variant here. You notice that there's one dominant anterior cerebral artery, unlike the case I just showed you, where there were two A2 segments. This is a variant of anatomy. This is called an azygous A2. And this is actually correlates with the presence of an aneurysm at the first bifurcation. So whenever you see that appearance, you should be thinking of the possibility of an atypical location for an aneurysm. Again, we see the MCA branches in the sylvian fissures. You can see a little bit of the basal ganglia here, lentiform nucleus, head of the caudate thalamus. And as we will go down, and again, now we see the A1 segment here, A1 segment here, joining over here into this single large trunk, as I say, the azygous A2. Here's the tip of the carotid. Now we're into the M1 segment, middle cerebral artery here and here. These are the posterior communicating arteries, right and left. The posterior communicators, of course, come off the carotid artery. They're the second large branch that comes off the carotid. These will join with the proximal posterior cerebral artery, and these divide the posterior cerebral P1 segment and P2 segments. And again, here's the optic strut defining the dural ring. Now, I just want you to notice in this case, and there was an abnormality in the skull on the previous case, this patient has a pituitary tumor. So just a reminder that as we look at CTA and focus on the vasculature, you have to also look at the soft tissues. And I try to make it a point in all of my CTA cases that when I'm done examining the vasculature, I go back and look at it as if it's a CT, or in the case of a head and neck CTA, you have to look at it like it's an ENT case as well. Posterior circulation, here we have the basilar. As we come down, the basilar, and then there'll be a branch that comes off the basilar here. This was going to be the anterior inferior cerebellar artery, dividing into this dominant right-sided V4 segment. This is a hypoplastic distal vertebral on the other side. This is what's called, this is a MR scan now. This is an MRA, and this particular view is called a collapse view. So you're basically taking all of the slices from the MRA and seeing them in a single projection. So in this view, we have sort of all telescoped into a single two-dimensional slice. This will be the petrous portion of the carotid. Here you see the carotid coming around. Here's the middle cerebral artery, basilar, posterior cerebral, and so on. So this view I find is actually very helpful. It gives you an overview of the vascular anatomy, and is particularly helpful when you're looking for vascular malformations, dural fistulas, that sort of thing, because all of the information is projected into a single view. This is another way of looking at the cerebral vasculature. This is a dual energy CT scan with bone removal. And here you can see nicely all of the vessels. This is a surface rendering of the data. This is a volume called volume rendered image. And here you see the carotid in its petrous portion comes up into its cavernous portion. This is going to be the distal carotid. This is what gives rise to the terminology of a T occlusion. So this is where the carotid joins with the A1 segment and the M1 segment. Here on the other side, again, this T appearance, distal carotid, A1 segment, M1 segment. Now, in terms of terminology, at one time, there was some distinction between the way neurosurgery described the M1, M2 junction in the middle cerebral artery, but most hospitals now in the US will use the convention that the first division of the middle cerebral artery is the junction of the M2 segment and the M1 segment. This would be the superior division. This would be the inferior division, M2. So superior M2, inferior M2, and the same way. Sometimes you'll see there's a trifurcation. This one is a bifurcation. The A1 segment comes across. We see the A2 segments coming up. This is the bridging anterior communicating artery. Here's the V4 segment of the vertebral artery, the confluence, basilar artery, and posterior cerebral arteries. You don't see very well on this reconstruction, but the superior cerebellar will come off in this fashion. So kind of a quick overview, and I just wanted to give you a sampling of some of the technology and the way we look at the vasculature. So let's look at some specific vascular territories. This, of course, is the anterior cerebral artery territory, and this is an MR diffusion scan. So you see this high signal intensity, which indicates we have restricted diffusion. The anterior cerebral territory comes to the midline. It hugs the midline, has this relatively sharp border here. This would be the distinction here between the anterior cerebral and the middle cerebral artery territories. Depending on the exact vascular anatomy, it may come farther back than this, a complete anterior cerebral infarct, or this one is truncated here. And we have some other flows probably coming from the posterior cerebral artery. So again, ACA territory infarct in this patient. This is classic MCA territory infarct, this kind of like big triangular shape here. You can see these angles. There's a little mass effect. There's loss of the cortical sulci that you see on the other side. So this, of course, is a subacute infarct. And as a subacute infarct, we have swelling of the hemisphere, a little mass effect on the lateral ventricle. You can see there's loss of the cortical ribbon here, blurring of the gray-white junction that you see on the other side. So typical appearance of a middle cerebral artery infarct. Just want to go through the basal ganglia again, reviewing some of the anatomy. This, of course, is the caudate head. This, and you see defined here, you see it on the other side. So it has a slightly higher attenuation on CT than the white matter. This is the white matter of the internal capsule, anterior limb, posterior limb. This is the lentiform nucleus composed of the putamen laterally, globus pallidus medially, and the thalamus here lies immediately adjacent to the third ventricle. So again, caudate, lentiform nucleus composed of the caudate, putamen and globus pallidus, and the thalamus. This is another diffusion MR scan demonstrating the posterior cerebral artery territory. Again, reminiscent a little bit of the anterior cerebral artery, relatively narrow border, but you see that there's the lateral portion of the temporal lobe is not supplied by the posterior cerebral artery, and the anterior border of the posterior territory, in my opinion, is around the temporal horn of the lateral ventricle. So let's look at this page. This is an MR scan. This is a flare scan. Fluid attenuated inversion recovery. And you know it's a flare scan and not a T1 weighted scan because the white matter is darker than the gray matter, which would be the reverse if this were a T1 weighted scan. So we see this abnormal signal. I would describe this as T2 prolongation in the frontal lobe. At this point, you might ask yourself, could this be a frontal lobe infarct? And we know seizures can accompany infarcts, but you'll notice that there's this wider area of involvement than I showed you in the previous example. Do you see the way that this extends more laterally, kind of fans out in this location? There's also swelling here, and presuming that this patient presented acutely, you should not have mass effect on the first scan. And the extent of this laterally, even though there is some variation in vascular territories, this appearance should suggest that this patient has a tumor as the source of their seizure. This would be a good look for an oligodendroglioma, and what this proved to be was a brain tumor, not an infarct. So I'm sure many of you have confronted that in your practice already, but this is not a trivial question in a lot of cases where we're trying to decide if we're looking at an infarct or a brain tumor. And I can tell you in my career, there have been a number of cases I can vividly remember where we were mistaken in our initial assessment, partly because the symptoms often are not helpful, in that some patients with brain tumors can present with infarct-like symptoms. So again, this is how vascular territories, understanding vascular territories, can help you with that distinction. A little bit of anatomy here. This is the midbrain. You can see the third cranial nerve coming off here in the cistern, from the cistern. Another case, here's again, sort of reminiscent of a subacute infarct involving the anterior cerebral artery territory, but as we go down lower, you can see this extensive mass effect and bilateral involvement here across the midline. And again, this is a brain tumor, not an infarct. So again, keep those vascular territories in mind as you're trying to make that distinction. Now, this is a different pattern of disease I want to show you. Here we have diffusion weighted imaging, but we see multiple infarcts here. This is in the MCA territory, PCA territory, MCA territory. This is probably pica territory on both sides. So this pattern of involvement, multiple vascular territories, infratentorial and supratentorial, this pattern would suggest some cardioembolic emboli coming from a valve. Clot in the ventricle can even arise from the ascending aorta, but this pattern is not one that would lead you to suspect a large vessel occlusion, which is, of course, the focus of much of the intervention these days. So again, this pattern of involvement should suggest to you the possibility of multiple emboli. Now, this is from Radiopedia. I don't know, I imagine in Armenia as well as here, people use this website regularly. I want to emphasize for you that I want your understanding of vascular territories to go beyond this sort of nicely colored, illustrated drawing. I think there's some errors in this drawing. I think the ACA territory doesn't go this far lateral. And specifically, I want to talk about this aspect of the drawing here. They indicate that the basal ganglia are supplied by the lateral lenticulostriate arteries. The lateral lenticulostriate arteries come off of the M1 segment. Here you can see this would come off of the N1 segment here. So with a proximal M1 occlusion, you often have infarcts that involve the basal ganglia. But there's a subtlety that I want to make you aware of here. So let's look at this case. So we can see this patient has had a previous craniectomy to decompress this large infarct. And as you know, steroids are not effective with infarcts the way they are with brain tumors. And we rely oftentimes on creating more space with a craniectomy to allow patients to survive these large territory infarcts, which would lead to a gross herniation of the brain, so-called malignant infarct. So if you look at this vascular territory involved, this is the lentiform nucleus, right? This is the thalamus. Thalamus we know is a posterior circulation structure, so that seems fine, that would look good. Makes sense that this would be involved with an MCA territory infarct. This is MCA territory as well. But as we go down through the slices, you can see ventricle, we're out of the ventricles, down lower. You see this involvement here and here of the most inferior portion of the caudate head. So if you're trying to decide if this is a carotid occlusion or an MCA occlusion, the involvement of the inferior portion of the caudate head should lead you to suspect this is a carotid occlusion and not an MCA occlusion. So this patient did indeed have a carotid occlusion. Here you see the normal carotid at the entering the skull base, and there's no enhancement in the petrous canal on the other side. So this is a carotid occlusion case. Now, how could I suggest that based on that involvement of the caudate head? And so this is a paper, it talks a little bit about that, and I think it's a nice illustration of the lenticulostriate arteries. Here you see these little branches that come off the M1 segment, see before the bifurcation, that supply the lentiform nucleus and much of the caudate. But you'll notice here there's a branch that comes off of the anterior cerebral artery, A1 segment, just before it divides here into the A2 segment. This is what's called the recurrent artery of Hübner, and this supplies the inferior caudate head. So the point here is that if you have involvement of the entire caudate involving the inferior portion of the caudate head, you have to suspect the occlusion is here in the distal carotid and not here in the proximal M1 segment. So again, the recurrent artery of Huebner supplies the inframedial third of the head of the caudate and the anterior inferior third of the putamen. So let's look at that in this case. Here's a different patient. So this is a non-contrast CT scan, and we see this territory involvement here. There's the normal cortical ribbon here. Here we see the white matter of the temporal lobe, temporal horn. If we go to the other side, we lose the gray-white junction that we see here. So this patient has a involvement of the patient's left temporal lobe. Notice the normal high attenuation of the cortex here in the medial temporal lobe that ends with the temporal tip. This is what I was mentioning to you, what I think is an error in this illustration, that the posterior cerebral artery territory comes up farther than is indicated here, and I think does not involve as much laterally as shown here. But this is an MCA territory sparing of the PCA territory. Now let's look at the basal ganglia in this patient. You see there's a little bit of the caudate and the putamen that is spared in this location. This would suggest that the A1 segment is patent and we're getting blood supply to these structures here in the inferior caudate and putamen, and yet we have involvement of much of the lentiform nucleus. So this one you would favor an MCA occlusion rather than a distal internal carotid artery occlusion. Again, broad involvement of the MCA territory, sparing of the ACA territory. You see again, this is anterior cerebral territory, anterior cerebral, and so on. And we come up here, you can see the sparing of the cortex here. Again, so this is limited to the M1, middle cerebral artery territory. I will tell you in cases that have gone to intervention, it's very common in patients who have a thrombus in the T junction or even in the proximal M1 segment that occasionally you'll see emboli that go out the anterior cerebral territory. You can have some little infarcts in the ACA territory post-intervention. This pattern of involvement, this is the territory of the anterior choroidal artery. The anterior choroidal artery comes off of the distal carotid artery, and it involves the posterior limb internal capsule. And as you would expect with an infarct in this territory, that these patients are usually hemiplegic as a result of this infarct. So again, anterior limb, posterior limb, this is thalamus, lentiform nucleus, head of the caudate. Now here's another patient, different pattern of involvement. And what I want to show you here, there's a dense carotid and middle cerebral artery here. You see this involvement of the MCA territory, sparing of the ACA territory, but you'll notice that that area of the anterior choroidal is also involved here, posterior limb internal capsule, actually a little bit of sparing of the basal ganglia here, but although it's blurred compared to the other side, MCA territory involvement. Now this involvement would suggest this is, again, a carotid occlusion rather than limited to the MCA. And the reason for that, again, this MCA territory here, the reason for that I want to show you is this is a digital subtraction angio. This is a lateral view. The patient has been injected. This is, you can tell this is a common carotid injection because we have some of the external branches that are filling here. But from this common injection, you can see contrast filling the petrous portion of the carotid, the cavernous portion of the carotid. Here's the takeoff of the ophthalmic artery. Again, the ophthalmic artery is the first branch, large branch that you see coming off of the distal carotid. The next large branch is the posterior communicating artery. Now, you'll see this posterior communicating artery is large here and then tapers as it goes back. This is what you would call a fetal origin of the posterior cerebral, and you would expect that this patient would have a very small P1 segment coming off the basilar, if any at all. But then the next small branch that comes off, this is the anterior choroidal artery here. So this is the third branch that comes off of the carotid before we get to the bifurcation into the A1, M1 segments. So what I want you to recognize is that if you have an occlusion of the carotid artery, we're going to lose flow to the ophthalmic artery, but that may not be manifested with vision change because we know that the ophthalmic artery can also fill by way of the external carotid artery. And for those of you that do ultrasound, you probably have seen cases where there's reversed flow in the ophthalmic artery in patients with a internal carotid artery occlusion, and this is one of the sources of collateral flow. So even though we lose flow into the ophthalmic artery, the patient usually doesn't manifest symptoms. If we lose flow into the posterior cerebral artery, again, this is connected to the basilar artery or posterior cerebral artery back here. So this can also fill from posterior to anterior. So this may not be manifest with any symptoms, but occlusion of the proximal anterior choroidal artery often will be manifested as an infarct. Now, in terms of distally, we know that we can have filling of the MCA and the anterior cerebral artery from cross flow through the anterior communicating artery. And I'll show you a case of that. So you can have isolated occlusion of the anterior choroidal artery. That doesn't happen that often with emboli. In fact, some of the cases that I've seen have been cases of PCOM aneurysms where the clip was positioned so that it interrupted flow into the anterior choroidal artery. But you can also see ACA occlusion as a manifestation of carotid occlusion. So keep that in mind as you look at this particular pattern of involvement. Which brings me to this topic. I want to talk a little bit about collateral flow because it is essential to consider this as we talk about vascular territories. The main sources of collateral flow are via the circle of Willis, leptomeningeal collaterals with reverse flow in medium-sized arteries, and recruitment of external carotid branches. So I mentioned this to you that you can have reverse, a good example is reverse flow in the ophthalmic artery in patients with carotid occlusion. Leptomeningeal collaterals, if you look for it on angiography, you'll see this relatively commonly. And this is probably the most common source of collateral flow and maybe the most important one. So this is a drawing from Frank Netter. Here we're looking at the inferior surface of the brain. So this is the optic chiasm. These are the optic nerve, optic tracts will go back here. And in this illustration, he's cut off the distal carotid, and this is where the carotid divides into the middle cerebral artery and the A1 segment. This is anterior communicating. This would be posterior communicating artery coming into the PCA here. So this network, ACOM, bilateral PCOM, makes up what's called the circle of Willis. And so in practice, what happens is with an occlusion, let's say there's an occlusion of the proximal carotid, that supply to the A1 segment and the MCA can come by way of reversed flow through the PCOM, or it can come by way from the other side across the anterior communicating artery. This kind of simple drawing is one that is meant to represent these different vessels, ACOM, A2, this would be the A1 segment, MCA, PCOM. So we can use this to kind of map out some patterns of involvement. So if you imagine that a patient has an occlusion of the distal carotid involving the A1 and the M1 segment, we can see collateral flow can arrive at the anterior cerebral artery coming around this side of the circle of Willis through the ACOM. And this is why with a distal carotid occlusion, you may not see involvement of the anterior cerebral territory. And can in many respects look similar to an isolated MCA occlusion as we've seen. So what you see on CT and MR is really a combination of the involved vascular territory minus those regions supplied by collateral flow. And collateral flow can be so ample that you'll see cases where the internal carotid artery is occluded, but the patient has no infarct of the brain. In fact, I have a friend who had as an adult, had a dissection, a spontaneous carotid dissection that went on to occlusion. And so on follow-up, he never recanalized his carotid artery, but he's completely normal, quite active. He's actually a practicing physician. And so his collateral flow through the circle of Willis was sufficient to supply the brain. So again, not every patient with an occlusion has symptoms because of this property of collateral flow. Let's look at this patient then. This is a maximum intensity reconstruction of an MRA. Here you see the common carotid. The bifurcation is tucked in here, kind of a tortuous distal cervical internal carotid artery, cavernous carotid, distal ICA, M1, A1. Now on this side, there's no internal carotid artery, and yet you see the cavernous carotid here, you see the A1 segment here, and we have filling of the MCA here. And so this patient is getting sufficient collateral flow, in this case by way of the circle of Willis, that vascular supply is provided to this contralateral hemisphere in spite of the loss of the internal carotid artery. And we can look at that in rotation. This is a nice demonstration of the vertebral artery. And so just to talk briefly about that anatomy, the vertebral artery, we'll talk about this when we get to posterior circulation ischemia, is divided into 4 segments. The first portion of the vertebral artery, before it enters the cervical vertebral foramen, is just called V1 segment. The second segment is the part that runs through the cervical vertebral foramen. Then there's this portion here that loops around at the upper cervical spine. This is going to be the V3 segment, and where the vertebral artery enters the skull base and before the confluence, this is called the V4 segment. And so again, here we see the basilar artery, superior cerebellar, posterior cerebral artery, and loss of the occlusion of the internal carotid artery on this side. And yet we have what looks like a perfectly normal vasculature if you look above the cavernous carotid artery. So a good example of circle of Willis providing collateral flow. This is from a digital subtraction angiogram. And in this patient, for those of you that do cerebral angiography, in this first frame, you realize there's something wrong with this picture because we see no blood vessels in here, which is the MCA territory. We should see the Sylvian branches at this point. And just to go through that anatomy again, this is it looks like an internal injection, ophthalmic artery, posterior cerebral artery here, PCOM here. This is probably anterior choroidal here. This is the A2 segment coming up as it winds around into the pericallosal artery. Now you see this absent area here. So this patient has an MCA occlusion with good filling of the ACA. Now watch what happens as we get farther in the run. We start to see these kind of odd looking vessels appear here, here. Now these are not veins. You see these vessels filling here, and they're sort of coming back, getting closer to where we saw the carotid artery, right? These are MCA branches that are filling in a retrograde fashion due to a network of collaterals on the surface of the brain in the leptomeningeal. So in this case, the anterior cerebral artery is supplying much of the territory of the MCA in this patient through these collateral flow. This is why you'll see patients who have a proximal occlusion of, for example, the MCA, and yet there's only a small infarct visible on the diffusion-weighted MR scan. This is also why it is possible to recanalize and have good recovery in patients with proximal vascular occlusions when you get to be 8 hours or even 12 to 24 hours out from the time of the onset of the symptoms, is because in those patients, we presume that there's enough collateral flow to at least support the brain, although this gives rise to this idea of a penumbra, that the quality of the perfusion may be impaired, and yet the brain can survive long enough for intervention to be effective. So keep in mind these patterns of collateral flow. Here's a patient with a large ophthalmic artery on the right side, and you can see this is the normal cavernous carotid here. There's no enhancement in the cavernous carotid on this side. So in this patient, and we can't determine that from CTA, but we presume this patient has retrograde flow from the from the ophthalmic artery coming back to the distal carotid here at about the dural ring. And that's what's providing flow to the middle cerebral artery in this patient, along with probably cross flow from the anterior communicating. So again, circular Willis along with external supply can support flow. So again, this is another pattern of collateral flow, comes from the external carotid artery. Here's a patient with Moya disease. This disease, as you know, results in a stenosis here in the distal internal carotid artery, and probably in stenosis here involving the middle cerebral and proximal anterior cerebral artery. And this network of collaterals here coming from the basal ganglia is what gives rise to this name Moya, which I understand means puff of smoke. So this is the puff of collaterals that arise to support the distal vasculature in these patients with this proximal stenosis, really of unknown cause. But I just want to show you that this is a patient with Moya disease that had a focal infarct. But I want you to notice this is the middle meningeal artery on the right side and the middle meningeal artery on the patient's left side. This is of course, the basilar artery, and you see very little flow here in both the carotids. So why is the middle meningeal artery so large in this patient? It's because the brain is starved for flow and is using the middle meningeal artery as a source of flow through these network of collaterals to provide some flow to the brain, obviously not sufficient to avoid this infarct, but again, an unusual, but still it adheres to the concept of the external branches can support collateral flow to the brain. Now let's look at this patient's involvement. Here we see this area of low attenuation, loss of the cortical ribbon. You see it adheres to this to the edge of the tentorium, the medial portion of the temporal lobe, sparing of the lateral portion of the temporal lobe. And this is unlike this drawing. This, I think, is a fairly typical pattern for a posterior cerebral territory infarct. This is the region of the visual cortex. This is why these patients will have a homonymous hemianopsia on the opposite side from the infarct. But again, this is a PCA territory infarct. Again, you would infer that this is subacute because of the loss of the sulcation here. And this is what you see not in the acute phase, but in the subacute phase where there's a little swelling. And there's some mass effect here on the atrium of the lateral ventricle. So again, illustrating the PCA territory. And you notice as we come up, this is the end of the ACA territory, and we get here into the PCA territory. And that brings us to some of these posterior circulation infarcts I want to talk about. This is that drawing you just saw, sort of an expanded view of the entire undersurface of the brain. Here you see the vertebral arteries coming up. These are the AICA, anterior inferior cerebellar arteries. These are the pontine perforators that come off left and right off of the basilar artery. These are small branches, but of course very important. Here's the superior cerebellar artery, posterior cerebral artery. This then is the third cranial nerve that comes through this space between these, like think about it going like a straw through your fingers. This is the cranial nerve coming through here. We talked a little bit before about the circle of Willis. Another image of the posterior circulation basilar, or I'm sorry, distal vertebral artery, V4 segment, basilar artery. This patient has an aneurysm at the origin of the pica. Pica comes off always from the vertebral artery. Aica, inferior cerebellar artery, always comes off the basilar artery. Posterior cerebral arteries here. So as we talk a little bit about, again, coming back to this, the impression you get here is that this is going to be the right PCA territory, left PCA territory, but in reality, there's some variations of anatomy I want you to be aware of. So again, I think the skills in neuroradiology or neuroimaging helps the patient because it's these subtleties that helps direct the workup and can lead you to the correct diagnosis. For example, in this patient where you have involvement of the left and right thalamus, it would be a mistake to think that this patient had a shower of emboli from the top of the basilar or bilateral PCA involvement because of this vagary of anatomy. What's called the artery of Percheron is a branch that comes off of one side but actually supplies both thalami. So bilateral thalamic involvement is not always an indication of bilateral vascular involvement. So I want to make you aware of that variation. This is another variation here you see on this digital subtraction angiogram. This patient, this is the left-sided vertebral injection. It shows something that's important. I want to bring to your attention is that the internal carotid artery does not have branches, muscular branches, but the vertebral arteries do. This is why the vertebral can reconstitute in its V2 segment, while the carotid artery with a proximal occlusion does not reconstitute in its cervical segment. So the vertebral artery here comes up, gives rise to a pica, but if you look on this image, you see this, there's vasculature filling in both inferior cerebellar hemispheres. This is because in some patients, and this is one of them, the pica actually supplies both hemispheres. So this is another example of where you can have bilateral involvement arising from disease involving a single blood vessel. One way you can think about the posterior circulation is there's the distal segment, which is the PCA and superior cerebellar, the middle segment, and the proximal segment, which involves the vertebral arteries and the pica. So aica is in this group, and the pontine perforators are also. So this infarct, you can see we're at the top of the cerebellum. It's involving the peripheral portion of the cerebellum, and you can see it hugs here the tentorium. This is a typical appearance of a superior cerebellar artery infarct. This infarct, you can see, you can draw a sharp line with like a ruler that divides this infarct on the right side from the left side. This respect for the midline is typical for pontine perforator infarcts. So these infarcts are very difficult to see on CT scan, usually requires MR imaging and diffusion imaging to find these infarcts, but this is a very typical appearance of a perforator infarct. Now I wanted to show you this patient, and this patient presented with, was in the hospital, had a low sodium that they were correcting when the patient became quadriplegic. Let's see, go back here. And so this patient, as we look, you can see this artifact through the pons. This is the, is it called beam hardening artifact? And this is what makes it very difficult to make any sort of reliable diagnosis in the pons on CT scan. You can minimize this infarct by using thin sections and so on, but in reality, this is kind of an area where MR is much more effective in making a diagnosis. Now, as we look at the MR scan in this patient, you can see that there's restricted diffusion in the center portion of the pons. You see this? This is what, this pattern of involvement should lead you away from the diagnosis of an infarct and suggest in this patient central pontine myelinolysis, CPM, or also called osmotic demyelination due to rapid correction of sodium. And so this is not the pattern of a pontine infarct, because pontine perforator infarcts, again, tend to involve one side or the other. Rarely do you have both, and you have usually comes all the way to the edge of the pons. So as I say, knowing these vascular territories can lead you to the correct diagnosis. This pattern of involvement, this is the posterior inferior cerebellar artery territory. Again, this is the typical pica territory along the bottom of the cerebellum, and this extends to the midline, which is more typical. So again, this is a pica territory infarct. And then this is another pattern of involvement, and this is the involvement of the medulla. You can see on the MR scan, this is a T2 weighted scan. This is T2 prolongation here. As a result, here on the MRA, you can see flow in both carotids, flow in the right V4 segment. There's no flow related enhancement in the left side. So this occlusion, it may not be of the pica. This can be just an involvement of the vertebral artery, because there can be perforators that come off of the vertebral that supply the lateral medulla. And of course, this gives you the classic lateral medullary syndrome. So in this last bit of this talk, I want to just talk about this in-between territory. You can see this patient has multiple small infarcts in a row, but this is not in the ACA territory. This is not in the PCA territory, nor is it really in the MCA territory. This is the in-between. This is what's called the watershed pattern of infarction. They used to call these top of the hotel infarcts. This idea that in some hotels, I don't know if you've ever had this experience in a house or a hotel, where if someone is taking a shower on floors below you, the water pressure drops enough that the upper floors don't have sufficient flow. So the same notion goes on here, that there's insufficient flow to provide enough blood flow to this in-between territory, this so-called watershed territory. So you get this pattern of infarction that involves both the cortex and the intervening white matter. And it tends to form like kind of a big loose C when it's from all the way from front to back. So again, this is going to be, it doesn't involve the ACA or PCA territory, nor the MCA territory. This is an in-between pattern of infarction. Here's another example. You see the cortex is involved here in a line between territories from this high-grade 90% really carotid stenosis of the ICA. There's several watershed territories that can be between ACA and MCA, as well as MCA and PCA. There's white matter involvement, as I showed you, between the deep arteries that low and those on the surface of the brain. There's also a cerebellar watershed, which is not widely known. This is a paper that demonstrates this watershed territory between the superior cerebellar territory and the pica territory. I saw this one time years ago. A patient came into the hospital with chronic hypertension, came in with a hypertensive crisis. They rapidly corrected the blood pressure, but presumably the blood vessels that were chronically vasoconstricted were unable to respond rapidly enough to this pharmacologic adjustment in blood pressure, and the patient experienced both the cerebral and cerebellar watershed infarcts in this territory along the horizontal fissure. So again, there are multiple watersheds in the brain, and this is a particular specific pattern of involvement. Here's the MCA, PCA territory watershed infarction. Now, again, sometimes it's hard to tell whether you're looking at embolic disease or watershed involvement. So be a little careful with this diagnosis, but I think it's an important one to recognize. In my experience, it tends not just to be that there is a vascular stenosis. Usually it's two things, either a tandem stenosis. It could be a stenosis with a proximal occlusion or narrowing. It could be a stenosis and the patient develops a cardiac arrhythmia, which lowers their blood pressure and perfusion pressure, and then combined with the stenosis leads to a watershed infarct. I think in this last illustration, I want to show you, these are chronic watershed infarcts. You can see this on the FLAIR scan, again, dark white matter. You can see these holes in the brain with some surrounding T2 prolongation in this white matter watershed territory. This is sometimes called the string of pearls sign. When you see this, don't ascribe this to age-related white matter change. This unilateral involvement, particularly if there's encephalomalacic change, should lead you to suggest in these patients there's an abnormality of the carotid. And so here on the MRA, you can see this is the normal carotid. You can see how narrow the carotid is on this left side in this patient who had a carotid dissection, chronic dissection with narrowing and insufficient flow.